So there have been the 51 non-repeat expansion diseases. The CAG repeat encoding polyglutamine is the most famous in the exon. And in the exon region, there is also polyadenine repeat, such as OPMD, oculopharyngeal muscular dystrophy. With the advancement of whole genome sequencing and long-read sequencing enabled us to find a new repeat expansions, especially in the non-coding regions, such as promoter, 5' UTR, introns, or 3' UTR. Oh, sorry. So please note that about 1/3 of the disease have been found from the Asia. So this slide shows the classification of repeat expansion diseases. As you know, there have been many neurological and muscular diseases. About 1/3 of the disease are spinocerebellar degeneration, such as SCA1, SCA2, Marshall-Joseph disease, and so on, followed by CGG repeat expansion diseases and BAFME, benign adult familial myoclonic epilepsy. I will discuss these diseases later. So how do repeat expansions affect cellular functions? So some repeats, some repeats cause a downregulation of the gene, and so it acts in a loss of function manner. On the other hand, the other repeats can act in a gain of function, a gain of toxic function. So at first, the transcribed RNA, repeat RNA can aggregate into the nucleus. So this aggregation of repeat RNA is called RNA foci. So the second, in some repeat expansion diseases, so the transcription of antisense strand can be found. So finally, so the repeat amino acid are produced from the repeat sequences. This is also, of course, this is caused by in exonic repeat polyglutamine from the CAG repeat. But in these days, this mechanism is also caused in the non-coding regions. This mechanism is called repeat-associated non-AUG-initiated translation, RAN translation. So the RAN translation is occurred in some repeat expansion disease, non-coding repeat expansion diseases, as well as in some exonic repeat expansion diseases in non-canonical frames. So let's start with spinocerebellar degeneration. So as you can see in the slide, there is 8 CAG repeat expansion diseases. And in the non-coding region, so the repeat sequences are very variable. Most of the diseases are autosomal dominant, but Friedreich ataxia and CANVAS are autosomal recessive diseases. So I will introduce here CANVAS. So the CANVAS, as the name suggests, it triads cerebral ataxia, sensory neuropathy, and vestibulopathie. So the disease is inherited as in autosomal recessive mode of inheritance. The cause of the disease is expansion of intronic pentanucleotide repeats in RFC1. In this disease, repeat sequences is very important. So normally, we can find AAAG or AAAGG repeat in normal subjects. But in patients, there are AAGGG or ACAGG repeat sequences are present. So So I will present two patients. So the first case is a 69-year-old female. She started to show gait ataxia at the age of 47. She started to use a cane at the age of 57. She showed dysarthria from 67 years old. So now she had difficulty to go out. She had sensory disturbance, and a history of dry cough was obtained. Dry cough is the typical finding in this disease. So the family history, so the parents are cousins, so they are consanguineous marriages, and nerve conduction studies show their sensory axonal neuropathy. So the Cowlick test was unresponsive, and head impulse test was positive. So this is rather typical findings of canvas. So second case is 81 years old male. He was suffered from recurrent syncope from the age of 20. He felt the dry cough at the age of 50, and he was pointed out sensory neuropathy at the age of 59. So his diagnosis was sensory autonomic neuropathy. From the age of 65, he felt pain attack. At the age of 81, sensory disturbance worsened, and he showed slightly unstable gait, and so vestibular examination revealed unresponsive ocular bend. So as you can see, the cerebral nerve biopsy shows decreased number of large myelinated fibers, but we can hardly see there is cerebral atrophy. So please note that not all the patients have three characteristic clinical findings. So this year, there have been two new repeat expansion diseases. One is ASNA2023. So the ASNA2023 is originally identified so the non-coding or nonsense or Fremskis mutation in FJ14 are the cause of ASNA2023, characterized by tremor and dyskinesia in addition to severe ataxia. Severe phenotype was found in knockout mice. So in this year, so GAA repeat expansions in the deep intron of FJ14 have been found in ataxic patients. So this GAA repeat likely cause loss of function or haploinsufficiency of FJ14. The new disease is reported by Chinese the neurologists. So this is exonic CAG repeat. This is the first CAG repeat in the quarter century. So there is still the limited number of patients and families. So subsequent follow-up studies are awaited. So here, I will introduce a benign adult familial myoclonus epilepsy, BAFME. So this is an autosomal dominant disease with adulthood onset. This disease is characterized by infrequent generalized seizures and tremorous myoclonus. The patient shows photosensitivity. Seizures are easily controlled with anti-epileptics, including valproate or clonazepam. The patient usually does not present with cognitive decline, so we call the name benign. So this disease is also called as various names, but this disease is relatively frequent in Japan, and the concept of the disease is established by Japanese neurologists, as shown here. So I would like to show a video. Can I use a video? Can I use a video? I can't find, okay. Yeah. So the myoclonus is not observed at rest, but observed in this posture. So the tremors movement is similar to essential tremor, but more irregular. If she take this posture, you can see the jerky movement like this, and you can see easily she has a myoclonus. So this patient is actually Bachman type 6. So the electrophysiologically, there is giant ACP and C reflex, and origins of this myoclonus is cortical. So to find a causative gene for Bachman, we found 51 families in Japan. To make a long story very short, we suppose a found effect and narrowed down the candidate region and finally found a cause. The cause is insertion of TTTCA repeat in an intron of some D12 gene, where short TTTA repeat is present in normal populations. So this repeat is present in introns. So usually we think that this is transcribed to RNA, but not into the proteins. So we performed RNA fish study using autopsied brain, and we can see this RNA foci containing UUUCA repeat transcribed from TTTCA repeat. So the repeat length is inversely correlated with age at onset. So that's great, but there are two remaining families. In these families, there is no repeat expansion in some D12. So we hypothesize that if TTTCA repeats in intron of some D12 cause Bachman through RNA toxicity, so the same TTTCA repeat in other genes can also cause Bachman through similar mechanisms. So this hypothesis was correct. We found insertion of TTTCA repeat in intron of TNRC6A in the upper family, and insertion of TTTCA repeat in intron of RAPGF2 in the lower families. So we named the Bachman type. So the most common type in Japan was Bachman type 1, and we named a new type as common Bachman type 6 or Bachman type 7. In other countries, there's Bachman type 2, 3, and 4, and other researchers finally found the same TTTCA repeat insertions were found in these diseases. So in summary, in Bachman there is an intronic TTTCA repeat expansion. So there is a strong correlation between repeat motif and phenotype. So the subsequent studies suggest that Bachman type 1 was found in China, Thailand, and Sri Lanka and India. So the researcher estimated that there is, or there may be 17, so there may be a common founder like 17,000 years ago. So I think you can see Bachman type 1 in the Asia. So next, I introduce NIID, neural internuclear inclusion disease. This is also autosomal dominant or sporadic disease, mainly late onset, and the patient that shows cognitive dysfunction, neuropathy, slightly decreased nerve conduction velocity, cerebral ataxia, autonomic dysfunction, and some patients showed encephalitic episode or retinopathy. So a brain MRI shows the T2 flare hyperintensity in the white matter and characteristic diffusion hyperintensity in the cortical medullary junctions. Although this is not observed in all patients. In these days, so the paravermal lesion can be found in NID. As the name suggests, internuclear inclusions are found in the central nervous system and peripheral nervous system, but also in somatic organs. Dr. Sone and colleagues found that skin biopsy is helpful for antemortem diagnosis of the disease, and this finding led us to find many more patients. So I will introduce another disease, oculopharyngodistal myopathy. This is also autosomal dominant or sporadic disease with adulthood onset. Dr. Satoyoshi in Japan found this disease. Ptosis, restricted eye movement, weakness in the face, pharynx, and distal limbs are characteristic of these diseases. So the muscle biopsy showed that the myopathy changed with limb vacuoles. So the patient shows normal brain MRI and normal cognitive function. Note that there are patients with very mild ocular symptoms, as shown in this slide. So what happened? Okay. So the clinical manifestation of NID is similar to FACSTAT, Fragile X associated tremor ataxia syndrome. And clinical manifestation of OPDM is similar to OPMD. So, yes, so it was our experience with one family that led us to identify the cause of these diseases. So this family showed oculopharyngeal myopathy, but also found showed MRI abnormalities similar to FACSTAT and NID. So originally, the leukoencephalopathy and oculopharyngeal myopathy were thought to be completely separated diseases. But we wondered if these diseases might be a spectrum, with the very extreme cases being leukoencephalopathy or oculopharyngeal myopathy. So because we did a research on Bachman, we suggest these diseases are also caused by CGG repeat expansions, because FACSTAT is caused by CGG repeat expansions in FMR1. And the hypothesis was correct. So the CGG repeat expansion is Notch2 NLC was found in patients with NID. CGG repeat or CCG repeat in LOC2 642361 and NTM2B antisense 1 was found in the family with OPML. CGG repeat expansion in LRP12 was found in OPDM. So we concluded that these diseases are all caused by CGG repeat expansions. So the subsequent studies indicate that CGG repeat expansion was also found in GIPC1. So this disease is called OPDM type 2. CCG repeat, so the antisense of CGG. CCG repeat expansion was also found in RILPL1. This disease is caused as OPDM type 4. Very interestingly, CGG repeat expansion is not to NLC, which is also found in NID, can be found in patients with OPDM. So, in short, CGG or CCG repeat expansion mutations now cause a wide range of clinical spectrums, from leukoencephalopathy and neuropathy to oculopharyngeal myopathy. The clinical spectrum should be called FNOP spectrum disorder from the acronyms of FACSTAS, NID, and OPML and OPDM. So in recent years, the development of oligonucleotide therapeutics and gene therapy for genetic diseases have been progressing. In Japan, nusinersen, an antisense oligonucleotide, and onasemnogen abepalbovec, and an AAV9 therapy for spinal muscular atrophy have been approved. So the RNAi treatment, vutrisiran and patisiran in transthyretin-related familial amyloidopathy have also been approved in Japan, which stops the progression of these diseases. So the one news is SOD1 linked ALS. So from the mouse models, gain of toxic function of mutant SOD1 has been proposed in this disease. So antisense oligonucleotides suppressing SOD1 that can be the treatment. So this trial shows the effect. So very regret-free. So the primary endpoint was not satisfied, but there is a decrease in the biomarker at CSF, neurofilament light chain, or a decrease the tendency for the decreased progression in the drug group versus placebo group. So this drug tofersen was gained accelerated approval in US. But the oligonucleotide therapeutics for repeat expansion diseases, however, are still in difficult situation. For the C9 or F72 linked ALS, there is GGGGCC repeat expansion in C9 or F. In this disease, there are antisense transcription and RNA foci formation and run translation the production in the brain. So to suppress these phenomena, so a trial using antinucleotide, so a trial using oligonucleotide was performed, but this drug do not show clinical benefit. So in the trial of Huntington disease, it was terminated. So at least it seems that much more research should be done for developing a therapy for repeat expansion diseases. So personally, I moved from Tokyo to Okayama last November. I would like to proceed molecular genetic research using next generation sequencers at Okayama. And we are also doing neuroscience research using mouse models for brain ischemia, dementia, or ALS. So we are also conducting a project in vivo directory programming from in vivo directory programming. This method converts glia cells to neurons in mouse brain. So in summary, I summarize recent advances in repeat expansion diseases. With whole genome sequencing and long-read sequencing, an increasing number of repeat expansion diseases are identified. We have to go further toward developing a treatment for diseases. So the Korakuen Garden is a famous garden in Okayama. This is one of the top 3 gardens in Japan. And if you have a chance, please visit Okayama. So thank you very much.